Today's topic is paracetamol toxicity. Paracetamol is also known as acetaminophen, and it is a very widely available over-the-counter drug, usually used for fever, right? So it is a very good antipyretic as well as it has got very mild analgesic activity. It is basically a non-opioid as well as non-NSAID drug, and it is usually found in several forms, in tablet forms, in solution forms, or per rectal formulations. Okay, so basically before going into the paracetamol toxicity, what you need to understand is the normal metabolism of paracetamol. If you consume paracetamol, it goes to your stomach and intestine, and finally it gets absorbed into the circulation. And once it gets absorbed into the circulation, it goes to your liver, where it gets metabolized to non-toxic compounds, right? Either sulfate moiety or glucuronide moiety by way of conjugation. Okay, so this paracetamol goes to your liver, finally gets metabolized to sulfate or glucuronide moieties by way of conjugation, and finally it gets excreted into urine. A small percentage, around 5% of paracetamol, will be converted into a toxic metabolite known as NAPK. NAPK is N-acetyl para-benzoquinone imine, which is a very toxic metabolite. It causes centrilobular necrosis in the hepatocytes as well as cytolysis. So NAPK is a very toxic metabolite which is mainly responsible for the liver damage. Under normal circumstances, the glutathione reserves in our body converts this NAPK into a non-toxic metabolite such as cysteine or mercaptopuric acid, and finally that is also excreted into urine. Whereas if you consume too much of paracetamol, and what happens is the glutathione reserves in your body gets depleted so much that the NAPK gets accumulated in the liver, and finally this NAPK will cause hepatocellular necrosis and liver damage, right? So any patient who is coming to the emergency department, he can come. The first question that you need to ask, apart from the routine age, sex, all these things, you need to ask is how much of paracetamol the patient has consumed. So according to the British guidelines, what they say is any patient who's coming to the emergency department, you classify them as either high risk group or a low risk group. These high risk group patients, who all comes under the high risk group patients. So any patient who consumes too much of alcohol, around like more than 21 units per week in case of males, or more than 14 units per week in case of females. That is one criteria to call it a high risk group. Second criteria is patients who are having some glutathione depleting conditions such as cystic fibrosis, malnutrition, all these things. And the third condition is if the patient is already on some enzyme inducing drugs such as carbamazepine, phenobarbital, phenytoin, all these things. So basically, if the patient is a regular alcohol consumer, if the patient is on some having some glutathione depleting conditions such as cystic fibrosis or malnutrition, or if the patient is having already on some enzyme inducing drugs such as carbamazepine, phenytoin, all these things, then you can classify them as high risk category. All other patients will fall into the low risk category. So for this high risk category, the cutoff point, like to call that, to label the patient as is having a paracetamol, has taken a dangerous amount of paracetamol, is 75 milligrams per kilogram, 75 mg per kg. If the high risk patient has consumed more than 75 mg per kg, then you need to be careful. You have to admit the case and treat it accordingly. Whereas in case of low risk group, in case of all these low risk group of patients, 150 mg per kg is the cutoff. All patients who have consumed more than 150 mg per kg, then you will have to admit and treat. Less than 150 mg per kg, you can actually safely discharge the patient, but you need to follow it up later on to look for whether there is any change in the LFT, liver function test, or not. So you basically admit these cases. One thing you need to understand is that paracetamol, the peak effect of paracetamol takes around peak levels of paracetamol in the blood will be at around 4 hours after consumption. So any paracetamol you consume, most of them will be absorbed, but the peak levels will be seen at around 4 hours. So if a patient has come to you within 1 hour of consumption, you will have to wait till 4 hours. Okay, after 4 hours only you are supposed to draw the blood sample to look for the level of paracetamol. Before that, there is no point taking the paracetamol. If the patient has come to you within 1 hour of consumption, if you take the blood levels, it may not represent the actual paracetamol level in the body. And one more thing, there is a graph called the Rumack-Matthew nomogram. In that Rumack-Matthew nomogram, it plot basically on the x-axis. On the x-axis, you have got the time after consumption of paracetamol, and along the y-axis, you have the plasma paracetamol levels. And the graph is such that it starts at 4 hours and it extends till 24 hours, right? And you are supposed to take the blood paracetamol levels and plot the blood paracetamol levels on this Rumack-Matthew nomogram. And if the blood paracetamol level is above this line, then you are supposed to give an antidote. Antidote is what? N-acetylcysteine. But if the paracetamol level values are below the line, you are not supposed to start the antidote, which is the N-acetylcysteine. N-acetylcysteine is what? N-acetylcysteine is basically a precursor of glutathione. I have already mentioned that the NAPK is the toxic metabolite which causes hepatocellular necrosis. So NAPK is converted into a non-toxic metabolite by glutathione, and now I have told N-acetylcysteine is the precursor of glutathione. So if you administer glutathione and N-acetylcysteine, finally you are basically aiming to increase the level of glutathione reserves in your blood, and thereby you are trying to protect the liver. You are trying to convert NAPK to non-toxic metabolite. So if the patient has come to you within 1 hour after consumption of paracetamol, like if it is an overdose, you can actually do a gastrointestinal decontamination. That is, you can actually do a gastric lavage to take out whatever paracetamol is there in your stomach outside. Okay, you can actually also give something called as activated charcoal, 1 gram per kg or maximum 50 grams. You can actually give via putting in a Ryle's tube. Through that you can actually pour it in the form of a slurry, so that it decreases the absorption of paracetamol from the stomach by around 83%. Right? And the main thing that you need to understand is that the effect of paracetamol starts within 1 to 2 hours, peaks at around 4 hours after consumption, and it stays there for quite some time. There are different stages of paracetamol toxicity. There are 4 stages. Within the first 24 hours, patient will complain of nausea, anorexia, vomiting, all these things. Okay, and from 24 hours to 48 hours, patient will complain of all these nausea, anorexia, vomiting and all these things. Apart from that, patient will also have a right hypochondrial pain. At times, hypovolemia may also be present. And in stage 3, which starts from 48 hours to 96 hours, and in this condition, patient will develop severe hepatocellular necrosis. Right? I've already mentioned, like towards the end, the NAPK causes centrilobular necrosis. Finally, it leads to severe alteration of liver function tests, especially ALT will be grossly elevated, and you will also find severely deranged coagulation parameters, and also at times you can also get renal function abnormalities also. And in stage 4 is a period of recovery. If the patient survives stage 3, at times patient can either go to hepatic encephalopathy and death in stage 3, or if he survives stage 3, he can go to stage 4. That's a period of recovery, and that will take a few weeks for recovery. These are the stages of paracetamol toxicity. Another thing you need to understand is that after 8 hours only, we need to send all these blood parameters like LFT, RFT, PET, INR, and also the ABG basically to look for the pH as well as the bicarb values. Also, why do you need all these things? Why do you need to send all these LFT, RFT, pH and all these things? Basically, you need to understand whether the patient has to be referred to a liver specialist or not. There is some other thing called as King's College criteria, which is basically to understand, to predict the mortality in patients who have consumed paracetamol. Right. In that criteria, there are few major things. pH, if it is less than 7.3 even after fluid resuscitation, and if the PT value is more than 100 seconds, or if the INR value is more than 6.3, or if the creatinine value is more than 3.8 milligrams per deciliter, then all these things point towards the very high mortality in case of paracetamol consumption. In all these cases, the patient has to be referred to a liver specialist. In the emergency department, what you need to understand is that within 1 hour if the patient comes to you, you do a gastric decontamination, wait till 4 hours, take the blood paracetamol levels, and if the blood paracetamol level is available within a few hours itself, you can actually plot it on the Rumac-Matthew nomogram. If the point lies above the graph, you need to start N-acetylcysteine as the antidote. If it is below the graph, do not start N-acetylcysteine. And later on, the N-acetylcysteine dosage, I need to mention it right now here. The N-acetylcysteine dosage for adults, it is 150 milligrams per kg given over 1 hour. There are basically two protocols, either the IV protocol or the oral protocol. The IV protocol is basically a 21-hour protocol. The oral protocol, it's a 72 hours protocol. The IV protocol, the starting dose is 150 milligrams per kg given over 1 hour, 50 milligrams per kg given over 4 hours, 100 milligrams per kg given over 16 hours. This is the 21-hour protocol, and all these N-acetylcysteine is basically given in dextrose 5%. In the first 150 mg per kg, you can give it in 200 ml of dextrose 5%. 50 mg per kg can be given in 500 ml, and 100 mg per kg can be given in 1 liter of dextrose 5%. That is about the IV protocol. In case of oral protocol, if the patient is not willing for IV injection, you can actually give N-acetylcysteine in the form of tablets. That's a 72-hour protocol. There you give 140 milligrams per kilograms per oral stat, and then you give 17 doses of 70 mg per kg N-acetylcysteine at a gap of 4 hours. So total will be 17 stat of 140 mg per kg, then 17 doses of 70 mg per kg N-acetylcysteine. This is the normal treatment that you give in case of a paracetamol toxicity, right? And apart from this, treat the underlying other, if the patient has gone into hypotension or all these things, give fluids, right? And if the patient, by the time you have already patient is already on treatment, if the patient develops some anaphylactoid reaction, then you need to discontinue the N-acetylcysteine infusion for a short period of time. Give whatever the supportive medications, the antihistamines or whatever it is, you give it, and finally you restart the N-acetylcysteine at a very low dosage. Okay, around 50 mg per kg you can actually restart. So basic idea is, any patient who is coming to your department with paracetamol toxicity, identify how much dose the patient has consumed, identify whether the patient has consumed a toxic dose or not, and when the patient has consumed paracetamol, and accordingly you draw blood samples for serum paracetamol levels, LFT, RFT, INR, creatinine, all these things you need to draw at suitable time intervals, and finally you are basically trying to convert the NAPK into non-toxic metabolite by giving N-acetylcysteine. This is the major treatment to be given in an emergency department, and if the patient falls into any of these King's College criteria which predicts mortality in case of paracetamol poisoning, then you refer the patient to a liver specialist. Okay, thank you.